So I think you need to make those, grouping of the patient, whether it is nociceptive pain, whether it is neuropathic pain, whether it is mixed kind of pain. And if you're trying to alienate them into the neuropathic pain, then you need to have the baseline assessment done at every level. That means you can use any one of those neuropathic pain symptom inventory, which again has 10 components, and then there are 0 to 10 grading for each component, starting from all those pinpoint squeezing, pressure, and all those kind of burning sensations. In addition to that, you have the, you can take the help of EDQ or pain detect questionnaire. You can also take the help, the sensory pain assessment. So there are different skills, and what you have is DN4, that the French skill which is there for assessment of neuropathic pain. So I'll not go into all those details, but you really need to take the help of these scales, have a baseline assessment, and see how far you can see and observe modulations. And if you have the best possible infrastructure, why not take the help of nerve condition studies and EMG? But that's an issue altogether different. You need to really focus onto the clinical diagnosis, your clinical examination, as Dr. Duraiya was talking about, and then you can always take the help of these investigations. So I'm sure these are the things which you need to.
So these are the few other things which should be incorporated in when we are assessing the patient. But I wanted to add something.
Yeah. Madhuri was raising a very valid question. It's all right to say that we need to know about the emotion and mind, etc. How do we know it? And Dr. Duraiya mentioned PHQ-9. PHQ-9, this is depression, and there is another scale called GAD, that is general anxiety disorder. There is a difference between anxiety and depression. Both you need to assess. If you assess it before and do whatever treatment you are doing, and then assess it afterwards, it becomes an objective evidence of the efficacy of your treatment.
So I'll be coming back to Sunita. So you can understand that whenever we are assessing the patient, the psychological aspect cannot be ignored. The type of the pain, whether sensitization is there, cannot be ignored. These are the two very vital aspects, that whether the sensitization is there, how much it is influencing the pain, what is the psychological condition, how much it is influencing the pain should be there. I'll be coming back to Sunita. Are we really doing these things? What is your opinion, and how should we changing this to incorporate these things in our clinical practice?
Thank you, sir. A valid question. Actually, changes are required and are being done. What does holistic approach mean? We take a history, I agree, we examine the patient, but what about his spiritual part, emotional aspect? That is usually neglected. What happens is when a patient comes with a bag of files, he wants treatment. Sometimes he directly comes and says, no, I want to get the intervention done, but that is not the way. We have to think that this is a new patient. We have to start from A and then see the patient. Many times he wants to disclose many things which he cannot in front of his relatives. So that isolation must be respected. We should look at his emotional aspect also and give the patient time. This is very, very important while taking history, where one has to give adequate time to listen to the patient, which will make a lot of difference.
Very important. We are many times in a heavy OPD, we are just with the next patient without listening. Listening can make a lot of difference. I'll be coming to the audience if anybody wants to add this to this point, that the way we are assessing, the way we have learned in our undergraduate studies, should it be changed? And if it's changed, in which direction it should be changed? Any opinion from the house? Anybody wants to comment on that? Yes. Michael, please. Please introduce yourself.
I'm Dr. Malinder from Rajiv Gandhi Cancer Hospital. Relating to my own experience, we have very little exposure to real painful patients in undergraduate level. And what I remember of my college days, I don't think we ever formally seen a patient in pain. Anybody introduced us to how to go about sort of documenting the pain, patient's pain profile or the pain literally. And I think it's very important that at the very lowest level or the earliest level in schools, we should expose the students to pain documentation and examination.
Very important. Any other comment from the audience? Yes. Please.
Thank you. Very good morning to all of you. I'm Dr. Amit Thapa from Calgary University. said in our MBBS days, we were taught that pain is basically a symptom where there's always a positive factor in it. So whenever we're managing a patient of pain, we as any doctor like to find the cause, and if we do not find the cause, we say it's all psychological. That's a basic tendency for most of the physicians. So that perception has to change, and definitely there's a very good article, a volume published by in Neurosurgical Clinics of North America in 2014. The whole volume was dedicated to pain management, and how they have described pain as a multimodal subjective experience, which has basically three components: cognitive, affective, and sensory. So what all nociceptive and neuropathic pain we are talking is basically sensory component, but cognitive and affective are two different vital areas. And these three components are better looked for whenever we're talking of intracranial ablative therapies. So that's a whole new ballgame which is now appearing just because of the premise that this pain is a multimodal subject appearance, and hence for just by dealing at the sensory component of the pain may not give the patient a complete pain relief. So that's why you should also target for cognitive and affective.
Very good. Dr. Jayas wanted to say something.
Sir, Dr. Jayesh Chakra, I am practicing the sugar. I want to, sir, highlight just two things. One, madam has said that the spiritual aspect. So it is, I have seen many cases of the cancer pain and other patients that we learn the patient, educate the patient's relatives and the patients regarding the some pranayama and the meditation techniques. So it will help very much to the patient to cover the emotional part and the spiritual part that already made sent the madam last class. Then second part, I have many cases sent to the patient to the diet therapy, to the
Therapeutic part will be coming. We are just discussing about how to assess what are the different components which must be incorporated. So spiritual aspect evaluation can be a good point, but still now we don't have that much of structured thing to incorporate those in our clinical practice. Definitely the psychological aspect and the sensitization aspect has been well structured to incorporate in the assessment part. But very important suggestion that those two can be in the future also be incorporated in the assessment.
The second part is the diet. Diet also play important role for the.
Okay. So in the assessment of the pain, so a lot of aspects are very much important. But right now, there are the two important aspects which can't be ignored and which are already structured, which is already evidence-based. One is psychological assessment, and second one is the sensitization assessment. How much the sensitization is influencing the pain to increase or decrease as when the patient is complaining of the pain. I'll be coming back to the management part now. That what are the changes required in the different aspect? Like at the beginning, I try to emphasize that being a basic subject when I am an anesthesiologist, whenever I am assessing the patient, I am always thinking in terms of the interventions. Whenever a neurosurgeon sees in terms of some more invasive interventions, whenever it is seen by some physiatrist, he thinks in terms of that. But a holistic approach should be a combination of all these things, and it should be starting in the hierarchy, the smaller first, less invasive first, less costly first, and then we should be going step up based on all these factors. So I'll go back again to Dr. Dureja, that whenever you have assessed the patient, now how should we approaching? What kind of modalities should be coming first? Like as I discussed, that there are a lot of things which might be less costly, there are a lot of things which may be more costly, all might be evidence-based. But how should we offer those step by step?
Good question. And as you mentioned, that most of the therapies which you choose should be evidence-based. Definitely, yes. Either based on evidence quoted in the literature, but in India, if you have good practice of and good collection of patients, your own data may serve as an evidence base for you, because you can't blindly follow what has been done in the West. We have seen that whenever we have followed people who studies from America, not been able to replicate the results in our patient. So if you have collected your own data, you can use those as an evidence-based data for your patient. Obviously, as everybody is agreeing to the fact that we should not jump to the intervention straight away, unless like it's a trigeminal neuralgia, I have no choice, I will jump to the intervention. But if it is a back pain, where there are other factors involved, the rehabilitative factors, cognitive factors, I will take control of those factors, pharmacological agents, and then jump onto the intervention, keeping in view the red flags and the yellow flags in mind. So, low cost, if you say basic physiotherapeutic approaches, pharmacological approaches, a small duration of bed rest in back pain patients can can't force upon an intervention. Just like surgery is earned by a patient, not forced upon. Similarly, interventions have to be earned. So if there is an impending neurological effect, or it's a pain which is persisting long duration, where you expect that sensitization might take place, you can go on to an intervention. But start with and then step ladder approach. Always a step ladder approach, one by one, one by one. You will not like to wait for indefinite periods, but you fix up a timeline with the patient that if there is no relief in 3 days, we'll do this. If there is no relief in 6 days, we'll do this. A step ladder approach, starting from the basics, going to the further advanced, and then later further advanced.
So, in your opinion, there are certain exceptions where we can jump into the intervention,
Yes.
jump into the surgery,
Absolutely.
but in all other cases, we should be starting within the steps,
Absolutely.
starting with the minimum things.
As I gave trigeminal neuralgia, maybe cancer pain, I will jump into the intervention because the other factors can be looked after simultaneously. Yes.
I'll be coming back to Dr. Saxena. In your experience, what is your experience? How many percentage in a rough need this jumping, means directly into the surgery or directly into the interventions, and most of the other patients which should be stopped, and what should be the first step after the assessing, what should be the first step to offer our patients?
Well, it's a very good question. As Dr. Dureja has already highlighted, in my personal experience, this jumping from, maybe you are starting with pharmacologic and then going on to intervention, almost to the extent of 35 to 45%. That's what I would like to say. But then, as Dr. Dureja said, in trigeminal neuralgia, you have no other option. But then with many other entities, if you start following up, like typical chronic neuropathic pain, diabetic peripheral neuropathy, or post-herpetic neuralgia, of course, things may vary from what you see in practice and what you do in institutional practice. You follow those steps, and the jumping process may be anywhere from 35 to 45%. But then here again, I would like to say that the intervention can also be of the other type also. Like a typical example of non-steroidal anti-inflammatory drugs. Patient has been put on NSAIDs, and we all know that when you start NSAIDs and patient happens to be elderly with a past history of, say, alcoholism or concomitant corticosteroid therapy, and suddenly you find that the risk of GI bleeding has gone up. So that's a very different issue where simply with pharmacologic therapy, that the intervention required is not what you would have done, but what the emergency people have done. So this is where I would like to, I don't know whether you really want me to talk about some of those aspects, but this is a typical example where you are in a loop, you really don't understand what wrong I have done. So that's one aspect. And then simply when you're starting your alpha-2 delta ligands, gabapentin and pregabalin, and you have not educated the patient with the possibility of that giddiness and dizziness happening in the first 3 or 4 days, that's another stage where you may have poor compliance and it may require another kind of intervention. So these are two typical examples which are very commonly seen in day-to-day practice. But the typical blocks of the intervention which pain physician does, in my practice experience, it comes to 35 to 45%.
I'll be coming back with a similar question to Madhuri. What do you feel that suppose you are seeing a patient and those patients who don't need the jumping, means straight we will be starting the steps. What should be your first step to offer? I understand that it varies with a different kind of diagnosis. But as a whole, when you are addressing the pain, when you are thinking of offering some analgesics, what is your approach? How you are choosing your analgesics? What are the